Dear audience, today I would like to share a case of Stevens-Johnson syndrome caused by anti-neoplastic immune checkpoint inhibitors for oral cancer. The chief complaints of this 42-year-old male patient were red eye, oral erosions, and skin rash presented for 3 to 4 days, as well as fever persisted for 9 days. The present illness was stage 4B squamous cell carcinoma of the tongue with lymphatic, skeletal muscle invasion, as well as lung metastasis. The patient first received glossectomy and bilateral modified radical dissection. 1 month later, concurrent chemoradiotherapy was performed. Finally, 1 year later, which was 15 days before he first visited our clinic for the chief complaints, PD-1 inhibitor pembrolizumab was given. Dermatological findings of this patient include maculopapular extension with atypical flat targets over upper chest and a body surface area erythema of 3%. Mucosa involvement of this patient include positive oral mucosal erosions and crusts. In our clinic, we found massive cornea and conjunctival epithelial defect for both eyes. According to these main findings, the major diagnosis, Stevens-Johnson syndrome, was made, for which pemphigus was ruled out. 4 days after visiting our clinic, findings of skin biopsy suggested epidermal necrosis and mild interface change, consistent with findings common in Stevens-Johnson syndrome that were described in the resources and references provided by clinical key students. At the same time, direct immunofluorescence staining suggested negative findings. After admission, fever episode was still noted up to 39 degrees without other infections. At this point, tumor necrosis or tumor fever is also possible. 2 months later, both blood pressure and respiratory rate dropped dramatically, and on the same day, this patient expired. Stevens-Johnson syndrome and toxic epidermal necrolysis are characterized by severe, multi-system, immunologic adverse drug reactions involving mainly the skin and mucous membranes, with mortality rate being 1 to 5% for patients with HAS and being 15 to 40% for patients with TEN. The difference between HAS and TEN was defined by the involved body surface area, with HAS involving less than 10% body surface area, overlap HAS-TEN syndrome involving 10% to 30% body surface area, while TEN involving over 30% of body surface area. According to resources provided by clinical key students, a convenient database provided by Elsevier, clinical findings of SJS typically include severe vesicular bullous form of erythema multiforme affecting the skin, mouth, eyes, and genitals, in which corneal ulcerations may result in blindness. Moreover, flat and atypical target lesions may be distributed on the trunk or be widespread, which were also presented in the case we presented earlier. Drugs are the most common etiology of Stevens-Johnson syndrome. Other causes of Stevens-Johnson syndrome include upper respiratory tract infections by mycoplasma and herpes infections. Moreover, it has been demonstrated that increased rash of HAS was highly associated with genetic alterations of HLA-B1502 and HLA-B5801, HIV infection, chronic kidney diseases, and autoimmune diseases. Specifically, drug-induced Stevens-Johnson syndrome comprises over 80% of all cases of HAS. These drugs include anti-epileptic agents, anti-gout agents, antibiotics, antiretroviral agents, and NSAIDs. On the other hand, viral-induced Stevens-Johnson syndrome are mainly caused by mycoplasma and herpes simplex virus. Pathophysiology of Stevens-Johnson syndrome include 4 theories that may explain how small molecule drugs might interact with human leukocyte antigens and T-cell receptors, which are followed by a chain of events leading to Stevens-Johnson syndrome. These models include 1. The heptene theory, 2. The PR model, 3. The altered peptide repertoire model, and 4. The altered TCR repertoire model. Initiated by the 4 theories, we can see in the pathological findings in Stevens-Johnson syndrome that multiple apoptotic keratinocytes throughout the full thickness of the epidermis and a subepidermal split are forming a bulla. Also, perivascular lymphocytic infiltration is present within the epidermis. Based on the above introduced physical findings, clinical presentations, etiology, pathophysiology, and histopathology, The diagnosis of Stevens-Johnson syndrome is often made upon clinical presentations and appearance of the lesions. When classic lesions are absent or when diagnosis is uncertain, skin biopsies are recommended. On the other hand, common differential diagnoses of Stevens-Johnson syndrome include toxic erythema caused by drugs or infections, pemphigus, pemphigoid, and urticaria. To rule out these differential diagnoses, detailed history taking and examinations are necessary. For instance, in the case we presented earlier today, pemphigus was excluded based on clinical presentations, skin biopsies, and direct immunofluorescence staining. Last but not least, rules of thumb for treating Stevens-Johnson syndrome with non-pharmacologic options include withdrawal of any potential drugs that may cause SJS or TEN, and careful dermatological management that may prevent secondary infections. Medications generally prescribed at acute stage of Stevens-Johnson syndrome focus on complications of SJS, which include antihistamines for pruritus, bruise compresses for cutaneous blisters, diet with plenty of fluids to ensure proper hydration, corticosteroids for severe symptoms in the acute stage, as well as intravenous immunoglobulin transfer for other severe cases. Thank you very much for this opportunity and your attention.